Good afternoon, everybody. Welcome to the Center for Indigenous Cancer Research monthly webinar series. Today, we're going to introduce Dr. Michelle Heiser. She's an enrolled member of the Dene tribe. She grew up in Window Rock, Arizona, the political capital at the Navajo Nation. She attended Calvin University in Grand Rapids, Michigan for her undergraduate degree in biology. After college, she worked with the Centers for American Indian and Alaska Native Health at the University of Colorado, Denver as a research assistant. While working there, she was involved in program evaluations of substance abuse and education programs in Alaska, as well as data processing of diabetes and healthy heart projects throughout the United States. She eventually moved on to the University of Minnesota Duluth in Minneapolis, to obtain her medical degree. Initially hoping to become a primary care provider for Indigenous peoples, she found her talents and interests were more in line with surgery. So then completed general surgery residency in Oakland, California at the University of California, San Francisco East Bay surgery residency. While in surgery training, she completed a year of research with Phoenix Indian Medical Center, PIMC, in Phoenix, Arizona. Her research focus included benign breast disease, breast cancer, and colorectal cancer in the Arizona American Indian population. Through her cancer research work at PIMC, she became interested in cancer care within surgery and cancer disparities, specifically regarding American Indians. Thus, she decided to pursue a fellowship in surgical oncology and is now a first-year fellow in a 2-year program at Roswell Park Cancer Center in surgical oncology. She's excited to continue her work in cancer disparities and cancer care with the Center for Indigenous Cancer Research at Roswell Park. Michelle is currently an active member of the Association for American Indian Physicians. She previously was involved in the Association of Native American Medical Students during her time in medical school, including serving as president of the organization. During her time in Minnesota, she partnered with the American Cancer Society, presenting cancer screening to local tribes in hopes to continue American Indian community engagement while in Western New York. So we wanted to welcome Michelle. Michelle is new to the area. I'm sure it's a pretty substantial change moving where she's originally from. And she is now what we consider part of our team, an important member of our team, adding many years of clinical experience. So we're very thankful to have you today.
Thanks, Will. I'm pretty excited to be here. Obviously, this talk is pretty large and all-encompassing. So each of these topics can kind of be, a whole book's worth of detail in and of itself. So I just am trying to kind of highlight the points that I think are the most important. An hour is kind of a long time to talk. So if you guys have any questions or comments kind of throughout, feel free to chat in the box below, and then Will can kind of interject and interrupt me as needed to kind of answer questions. But there'll also be time for questions at the end, but I'm happy to be here and hopefully people can learn a little something from the talk today. So I can just a little overview of my talk today. So I'll kind of give a background. I know everyone is kind of coming from different experience levels here. So some people may be really familiar with American Indians and other people not so much. And some people really know a lot about breast cancer and others don't. So I'll kind of give a brief overview of those things individually, and then we'll kind of talk about breast cancer by race specifically, and then kind of the limitations of the American Indian breast cancer data that we do have. And that will kind of lead me to the problem of the urban Indian, and then problems of racial misclassification in the data sets that we do use. And I think this will kind of highlight the importance of using regional data and for different tribes to kind of gather their own information to kind of better inform these things. So just a little bit about American Indians in the United States. There's 574 federally recognized American Indian nations in the US today, and that's not including the 245 non-federally recognized tribes that exist. And this is an important distinction only because it matters for access to Indian healthcare service, which is where a lot of our data comes from. And I'll talk about that a little bit later. But in 2010, from our census, it showed that there are about 5.2 million people who self-identified as American Indian Alaska Native. And it's estimated that in 2060, there'll be about 10 million people, and that will constitute about 2.4% of the nation as a whole population. And the thing to kind of note within this is that this is a very young population overall. So 29% of Native people are under the age of 18, and in some states, this can be as high as 41%, mostly in the Dakota areas. But this becomes important, especially when we're talking about cancer care, because cancer, yes, it can affect different ages at different parts of lifetime. But in breast cancer specifically, this tends to be a cancer of older ages. It's hormonally driven and usually affects postmenopausal women. So as these indigenous populations get older, this will be a more and more important topic. So just so people who don't know, American Indians and Alaska Natives are really spread throughout the United States. I think a lot of people take that for granted and don't understand how all-encompassing within the United States this can be. Obviously, there are more hot spots or areas where these people tend to have reservations or tend to be in higher populations, and those are specifically Alaska, and then in the Southwest where Navajo Nation Hopi land is, Oklahoma tribes, and then in the Dakotas, the Plains Indians, and then Montana, you have the Blackfeet. But you can see here, basically all of the United States has some indigenous population representation. So a little bit about breast cancer itself. Cancer overall is the second leading cause of death in the United States, and breast cancer specifically is the most common cancer diagnosis in US women today, and that's excluding skin cancers, and it's the second leading cause of cancer death among US women. And most people will know somebody directly affected by this because 1 in 8 women will be diagnosed with invasive breast cancer during their lifetime, which translates to about 13% of women. And 82% of breast cancers, like I said, are diagnosed among women who are greater than 50. So they're postmenopausal usually, and then about 90% of breast cancer deaths also occur within this age group. So a little bit about breast cancer staging, because this is kind of how we look at outcomes and things for breast cancer data in general, is that we historically have staged breast cancer according to the tumor size, the lymph node status, and then distant metastases. So breast cancers are the tumor size. A T1 is generally the best, where the tumor size is less than 2 centimeters. T2, it gets a little bit bigger, it's about 2 to 5 centimeters, and T3, it's over 5 centimeters, and then T4 lesions are ones that extend and involve the skin or the chest wall itself. The lymph nodes are, N0 means you don't have any lymph node involvement, N1 is when you have metastases from the breast cancer to the axillary on the same side as your breast cancer, but those axillary lymph nodes are usually movable and not matted down. N2 means they're still on that same side, but they've become more fixed and involve kind of more of the surrounding structures. And then N3 means they've metastasized to other parts of the lymph nodes outside of the axilla itself. And then metastases, we're talking about breast cancer has traveled to other parts of the body or other organs. And so this leads us to 2018, when we learned more about breast cancer and how hormonally driven it is. In 2018, breast cancer also became staged by the tumor grade, how aggressive it was, and then whether or not it showed estrogen, progesterone, or HER2 receptors. And the reason this is important is because we have targeted hormonal therapies for these. And so usually if people have these receptors shown within their breast cancer, we have hormonal therapy that can target that, and these people usually do better. It's real easy to get lost in the weeds here in terms of the staging, but I think what I really want you guys to kind of take away from this is that stage 1 is usually the best. Most people usually know that, and those are the smaller cancers that haven't really gone to the lymph nodes. Stage 2, they get a little bit bigger, and some of them involve the lymph nodes. Stage 3, these are usually the bigger tumors themselves that have more matted lymph nodes, and then stage 4 is when it's traveled to other distant disease. So when we talk about it in a surgery kind of perspective and just oncology perspective, stage 1 and stage 2 is usually considered the early breast cancers, and these are very treatable with things with surgery, and then usually we'll have hormonal therapy. Locally advanced, you can still treat it with surgery and have hormonal therapy, but when you're getting into the stage 4, these are really the more chemotherapy type treatments that you get. So as far as the hormone receptors go, I'll talk a little bit about this later too. So I just want you guys to have an idea of what it means in translation. And the most common breast cancer that people have is ER/PR positive, so the estrogen, progesterone positive cancers, that's the hormone positive, and then the HER2 negative. These represent 73% of all breast cancers, and these usually have the best prognosis because of the medications that we have to treat it. The next most common is the ER/PR negative and the HER2 negative. And so this would be termed triple negative, and these usually have the worst prognosis and generally affect, for whatever reason, whether it be genetic or other factors, tend to affect minorities, specifically African-American women, and have an overall worse prognosis because we just don't have the hormonal therapy that can target these types of breast cancers. And then the other two have kind of a variety of the hormone receptor statuses, which we don't need to really get into that much, but that's kind of what I want to relay to you guys, and hopefully you can kind of understand that as we go through the talk. So breast cancer data, obviously, this is not something that you know ahead of time. It's all retrospective data based on things that have already happened. So the breast cancer data that we have for the future or for the current year is usually an estimate based on the incidence and rates of cancer that occurred in the previous few years. So in 2019, they looked at the 2013 to 2017 data and then projected what it would be in 2019, and they're doing the same for 2020. So based on these estimates, approximately 268,000 new cases of invasive breast cancer will be diagnosed among US women, and about 41,000 of those will die from their breast cancer. And overall, since 2004, invasive breast cancer incidence has risen about 0.3% per year. And a lot of this we think is because of increasing BMI or obesity within our populations as a whole within the United States. Because what a lot of people don't know is that obesity and fat cells themselves can secrete hormones. And because we already talked about breast cancer being a hormonally driven cancer, these can increase your risks of getting invasive breast cancer. The other thing is that fertility rates within the United States have overall declined, and people who have children because of the hormones within their breast tissue with breastfeeding and things like that, that's actually thought to be a breast cancer protective thing. So as these things change throughout the United States, this is what's sort of accounting for the overall incidence in the breast cancer rates going up. So when we kind of look at this by race, during 2012 through 2016, breast cancer rates increased in American Indians and Alaska Natives by about 1% per year. And historically, American Indian, Alaska Native tribes have not had the best screening practices. And so a lot of what people thought this increased rate was because we were now having better screening practices and process, meaning people were getting mammograms and we were detecting earlier stage breast cancers or just cancers in general that were just not presenting with somebody having a mass that they palpated. So theoretically, if you're doing more screening, you should be able to catch breast cancer at a much earlier stage. And in translation, breast cancer death rates should also decline because you're catching these breast cancers at an earlier, more treatable stage. Unfortunately, even though it's decreased the death rate in all other races, it's remained relatively stable within American Indians and Alaska Natives. So this can't be accounted for by screening, and there's something else going on within this population. So here is just a graph that shows us the incidence and mortality by race, and you can see American Indians and Alaska Native are at the middle of this graph, and this is rates per 100,000 people. And you can see our incidence is actually pretty similar to Hispanics and Asian Pacific Islanders, and less than non-Hispanic whites and non-Hispanic Blacks overall. However, you can see that our mortality is actually higher than the other two races that are about the similar incidence to us. So there's something else going on here. And the overall trend in female breast cancer incidence rates since 2001 have also shown these things to be increasing. And you can see that overall, most of Asian, Pacific Islanders, and Hispanics have also been increasing, with non-Hispanic whites and non-Hispanic blacks kind of decreasing to kind of stabilizing. And when we look at the death rates by race and ethnicity from 1975 to 2017, you can see that non-Hispanic blacks and non-Hispanic whites have had quite a decrease in their overall death rates. And then our rates have kind of increased a little bit and then kind of leveled off and have been increasing again. So that kind of gives you an overall perspective of things in terms of how we relate to other race and ethnicities. And then, like I said before, the incidence between 1999 and 2015 in white people, that incidence has been decreasing. It's been about 10% less. And then for us, it's been up about 8%. So I think in American Indian, Alaska Native women, you know, these incidence rates have been increasing significantly over the last 15 years. And yes, some of this could be attributed to the increasing rates of screening within the population. But I think one of the things that we have to also understand is that we're still underperforming in a lot of different ways for breast cancer screening that we should be doing. So according to the Government Performance Results Act measures, breast cancer screening has overall increased, but is still well below the Healthy People 2020 targets and screening rates for other racial ethnic subgroups. So it makes you wonder if that we did actually get to the numbers that we're supposed to be getting to, if our incidence would be much more significantly higher. The death rates would probably still not change a whole lot, mostly because if you're gonna get breast cancer, you're gonna get breast cancer whether or not you find it early. So I think overall this talks a lot to the importance of getting screened. And when we look at American Indians and Alaska Natives, when we look at kind of what stages they present at compared to other races, we are less likely to be diagnosed with a local stage breast cancer. So it's usually more advanced. And the metric that most of all these studies look at is compared to non-Hispanic white patients, because that's the data that we have the most of. And you can see that we are more likely to have more distant metastatic disease. And if you look at the 5-year breast cancer survival by stage from 2009 to 2015, American Indians and Alaska Natives are represented with the pink here. And you can see that our rates overall in stage 3 and stage 4 have, compared to, if you want to look at the compared to non-Hispanic whites, which is usually the benchmark, we have higher rates of those numbers in stage 1 and stage 2. We're about the same to a little bit less. So in most of these studies, when we look at breast cancer, it's helpful to look at breast cancer by region or by state, because each of these places is different, right? There's different environmental factors, there's different behavioral factors, and there's different kind of reproductive fertility rates within each different region. Unfortunately, for American Indians and Alaska Natives, the numbers are just too sparse to really be able to provide state level data for American Indians and Alaska Natives. But there have been a few studies that have tried to look at that. In one study in particular from 2012 to 2016, they found that the incident rates were twofold higher in women in Alaska and in the Southern Plains compared to other areas. And then those in the Southwest had a much lower rate of breast cancer. And so, like I said, the breast cancer rates overall being lower within American Indian and Alaska Natives really needs to be teased out with kind of regional variation because of the different factors that kind of go into what make people more at risk for breast cancer itself. So if you look at this graph here, this is from that same study that looked at the different regions. And so overall, American Indians, Alaska Native compared to non-Hispanic whites had a less risk. So it was a 0.87 here on the left. And then for Northern Plains, it was a slightly higher at greater than 1 relative risk. And then Alaska was much more high at 1.26, and Southern Plains as well, with the Southwest being the lowest and then the East. And a lot of these divisions are based on Indian Health Service data, which I'll talk a little bit in a minute. And then I think even if with all of these numbers that we do have, we have to look at some of the quality measures for breast cancer centers in general, because there is a expectation of rapid initiation of care from first diagnosis, and there's actually national quality measures for this in regards to timeliness of care. And there have been a couple of studies that have looked at how quickly American Indians receive cancer-directed therapy, and have found that within the first month of diagnosis, only 67% of American Indian women receive the cancer-directed therapy that they're supposed to get, when compared to Hispanics, who get about 90%, and then non-Hispanic whites, who get about 92%. So I think overall, we know that American Indian and Alaska Native women are at much higher risk of presenting with stage 4 tumors. They're more likely to be diagnosed with the ER/PR negative breast cancer, which we know is worse prognosis because of the hormone-directed therapies that they can't get to really treat them. And then this ultimately leads to a greater risk of disease-specific mortality as a result. So I think when we look at these data, we really have to think about what is informing this information. And I think before I started doing research in this area, I sort of took it for granted, and I didn't really think about where the incidence data and mortality data were coming from. And then when I started to look at it, I was sort of a little disturbed by it, because it's really only drawing from about half of the American Indian Alaska Native population. Alaska Native, granted, is a little bit better. But the incidence data that we do have is collected by the National Cancer Institute's Surveillance, Epidemiology, and End Results Program, and the Centers for Disease Control and Prevention's National Program of Cancer Registries. And what these places do, so SEER specifically started collecting data cancer information in 1973, and it was a limited number of states and a limited number of metropolitan areas. Since that time, it has expanded. And usually there are other registries that they try to combine with these to get a better, more encompassing view of what's actually going on in different communities. But I think it's important to understand that this is not all encompassing. Obviously, it's a little bit hard to do in general, try to get population level data. But these are the SEER cancer registries that we do have currently. And you can see that it's actually a fairly limited amount of areas around the country. And like I showed you before in the previous map of the United States for indigenous populations, we're throughout the United States. We're not just in these select states that are listed here. Thankfully, I mean, they are collecting data on Arizona natives and Alaska natives and the Cherokee Nation, but it's also not very representative of the American Indian and indigenous population as a whole. This is from the CDC. So obviously they have a lot more states that are represented within their data sets. And so a lot of these studies try to pool all of this information to give us the best representation of what's actually going on. And the coding within each of these systems is done race by race fields and cancer registry or data linkages with the Indian Health Service. And the Indian Health Service only includes what's called contract health services delivery areas. And so I'll talk about these as CHSDA from here on out, because it's a pretty long name to keep saying. But these counties specifically really only include all or part of a reservation, as well as those that share a common boundary with a reservation. And I'll show you a couple of more maps a little bit later to kind of illustrate this point. But mortality rates for American Indians and Alaska Natives are based on case deaths in these areas, also known as purchase referred care delivery areas. So they kind of use those two interchangeably. CHSDA was what they were used to be referred to, but the studies kind of go by both. So ultimately what we know is that these counties only represent 53% of the US American Indian and Alaska Native population. So a little bit about the Indian Health Service, because I know not everyone on this webinar probably is familiar with it. It's basically the U.S. Department of Health and Human Services provides healthcare through the Indian Health Services to federally recognized American Indian, Alaska Native tribes. And they do that through direct Indian Health Service, as well as tribally operated and urban health clinics. There's about 2,000 facilities throughout the United States, and it serves about 2.56 million American Indian and Alaska Natives. And about 64% of IHS service population reside on tribal lands. There are some urban Indian health organizations. There's about 41 throughout the United States, and about 600,000 American Indian and Alaska Natives are eligible for care through these things. And like I said, these only apply to federally recognized tribes. So the 274 that are non-federally recognized are not included in this population. So the CHSDA and the PRCDA counties are listed here. So you can see Alaska is actually very well represented within these care delivery areas, and so is Oklahoma and most of Arizona and Nevada. But the rest of the country doesn't have a whole lot of representation, as you can see. And so that kind of brings us to a dilemma when we try to translate these data, because we know that American Indians, Alaska Natives are throughout the United States, and specifically urban areas. So that leads us to the problem of the urban Indian. So over half of all Native Americans live in urban areas. And a lot of this is because of, obviously there are job opportunities in more urban areas compared to rural areas. There's a lot of people leave for education and then just don't go back to the reservation. And there's just overall more opportunities for people in urban areas. But also, I think one of the things that people forget about is a lot of people ended up in urban areas also because of the Indian Relocation Act in the 1950s. And for those of you who don't know, this was an effort by the federal government to cut federal funding to indigenous tribes and try to assimilate Native Americans by moving them to cities and eliminating reservations as a whole. So they actually tried to incentivize people to move off the reservation and go to urban areas to kind of reestablish themselves and become assimilated in the ways of the world. So the American Indian Relocation Act, the original sites were in San Francisco and Oakland, Los Angeles, Denver, Salt Lake City, Chicago, Dallas, St. Louis, Cleveland, and Cincinnati. And I'm sure a lot of American Indian people will tell you that they know or have a relative. I have relatives who are part of this Relocation Act. So that's how a lot of people also end up getting to urban areas. So now LA County has the largest urban Indian population in the US, and they cannot utilize Indian Health Service facilities, only contracted health services. And within LA County, there are about 250 different tribes. And similarly in Colorado, about 43% of the American Indian population resides in Denver, but the closest Indian Health Service facility is 390 miles away. So really only about 10% of all urban American Indians can use the Indian Health Service. And so if we're drawing our American Indian and Alaska Native data from the SEER database and things like that who are using Indian Health Service or contract areas, you can right away see the real limitation with drawing urban Indian representation or population within that data set. And even the urban Indian clinics that people are accessing through IHS, they have a very small budget. It's usually only about 2% of the total Indian Health Service budget. And usually these programs are related to substance abuse treatment, and it's not usually related to primary care or cancer care at all. So this just shows you kind of where a lot of urban Indians are now, and the cities that have the largest American Indian population. And you can see a lot of these places are not on the areas that are represented in the maps that I showed you before. So San Francisco, Los Angeles, San Diego, Portland, Seattle, Minneapolis. I'm actually kind of surprised Phoenix and Las Vegas are not on this map. But again, this is from 2000, so I'm sure that now there's probably even more. So aside from the whole problem of having urban Indians who aren't being counted at all, so about 50% of American Indian Alaska Natives aren't being counted, we have this whole issue of racial misclassification. So this is a statistically significant problem for American Indian and indigenous population within the United States, and we're more likely to be misclassified than any other race. And it's thought that American Indian data overall is undercounted by at least 38% nationwide. And it's funny because one of these studies even had them look within their own Native American cancer initiatives, staff working in urban areas, and looked at their medical records. And this was back in 1994. And the full-blooded American Indians who were getting care there were actually listed as Hispanic white or white on their own medical records. So you can see this is a huge problem. And Dr. Jim and her colleagues did a great job of kind of highlighting this as well, and showing kind of how certain areas can get it better than others. And they found that American Indians and Alaska Natives who die in counties with high concentrations of American Indians, Alaska Natives, are more likely to be classified correctly on death certificates than those who died outside of those counties. So the counties that I talked about before, the CHSDA ones, those usually do a pretty good job of identifying correctly on death certificates who actually is American Indian Alaska Natives. And I think I was a part of one of these webinars last month just as an audience member, and I think the moderator was saying, or the speaker was saying, that you are born an Indian but you die a white person, and I think that's still very true. In a way that a lot of people are trying to get around that is to decrease the misclassification that we're experiencing is by matching Indian Health Service patient records with the National Death Index to try to get a better percentage of correct classifications, because they found that inconsistent classifications within American Indians range from 1.2 to 30%, which is a really high number. And then, as you can see from the map, SEER actually covers Alaska really well. They have a really good representation within IHS, CHSDA counties. And so their racial misclassification is lowest, followed by the Southwest and the northern regions. But those also, like I said, correspond with the highest percentage of the CHSDA counties. So some other reasons for misclassification is, like myself, my last name is Heiser, which is European Dutch. So if I die and nobody knows me around, they would probably classify me as non-native. So a lot of these people have mixed racial backgrounds, European and Hispanic surnames, and are more likely to be classified as non-native on death records. And then migration between urban and rural tribal areas is very common. So a lot of people will have multiple addresses within a year in either urban or rural areas, which makes it hard to track or classify people. And then also, I think due to the historical trauma that has happened within American Indian, Alaska Native tribes, there is actually real fear of discrimination, which causes people to misstate their heritage purposefully on official documents. And so I think overall, this really underestimates all-cause death rates and cancer incidents among American Indian and Alaska Native populations. And I think the way to get around this is that we really need to do more regional, individual tribal studies to look at what actually is going within each tribe or region. There have been a couple of studies that have done this, and obviously these are retrospective reviews, and these also generally are within Indian Health Service facilities. The ones that I specifically had seen were in Montana, Wyoming, and Phoenix. And overall, it showed that the mammography prevalence rates among American Indians who were at screening age, which was 45 years and above, were pretty low at only 38%. And then for secondary screening, after people found a problem, only got 59%. So still pretty low numbers. And a lot of people who were presented initially with physical symptoms, and they weren't actually found on digital mammography screening. And so as a result, most of these people presented with distant disease. And in these studies, they found that there was an increased likelihood of regional or distant disease with increasing BMI. And also they found that treatment was inadequate in about 21% of the people who were treated, and they were more likely to receive mastectomy. These were a little bit older studies, and I know just based on my own experience working with Phoenix Indian Medical Center that overall these numbers are getting better. So there has been a lot of cancer, breast screening initiatives that have been happening that these data just don't capture. So I think overall, American Indian populations are very aware that this is a deficit and have been actively working towards changing that. And I do think that as far as the treatment being inadequate, so especially with the mastectomy, I think the standard of care now overall is to try to do breast conserving therapy as often as possible. But doing breast conserving therapy requires a lot of people to get radiation afterwards, and that commits you to going to a radiation center often. So a lot of people just don't have the transportation and will opt for a mastectomy because they don't have to do the radiation portion of it. So like I said, the data lag local efforts, and I think there are a lot of really good local efforts, and Rodney Herring and his group here have done a good job of looking at the regional data and identifying problems within this region of Western New York specifically, and have started to implement programs based on that. And some of those things are like Patient Navigator, and then also screening initiatives. And you can see here, this is some of the screening initiatives for breast cancer and cervical cancer that are happening now through the CDC. And you can see that there are a bunch of Native American tribes on this list. So I think that our incidence may go up because the screening goes up, but I think hopefully that will ultimately translate to lower stage, or increasing our capturing these breast cancers at stage 1, stage 2, where they're not distant metastatic disease, and making them more treatable with better prognosis. So in conclusion, I think it's really important that Native American communities continue to their efforts of screening, and hopefully to kind of stage shift their populations to get them at stage 1, stage 2, instead of the stage 3, stage 4. We do need to get better methods to collect urban Indian health data, because that's just half the population that we're already eliminating within these data sets that we just aren't able to describe. And as we know, each of these places kind of have their own risk factors that could influence their breast cancer risk or other cancer risks specifically. So I think continued regional efforts to define the breast cancer problem within Native American communities is really important, because the regional variation will help to explain the differences in environmental, behavioral, and reproductive breast cancer risk factors, and help us better understand and address the causes of breast cancer within American Indian and Alaska Native women. That's all I have. So if anyone has questions.
Wow, you covered a lot of ground in 40 minutes or so. I mean, it covered really hard-hitting topics that I think that we all, with the Center for Indigenous Cancer Research, we deal with every single day. We see these things every day. I think you really illuminated these issues perfectly. And especially, I think the one that's, I think, really important to understand is the way data is captured. We had this conversation earlier with the American Indian Cancer Foundation, and just in terms of screening rates, cancer screening, we said we don't really know our local screening rates. We have some regional, remotely regional data, but for specifically our area, we don't really know. And that lends to a discussion about data sovereignty, which is, I think, could be its own presentation, its own discussion is about data sovereignty. And we don't have any questions yet in the chat box. So for folks who are still on the line here, if you wanted just to chime in and ask the question directly to Dr. Heiser, that's welcomed as well. You can also put them in the chat box. But you mentioned earlier that many, if not, the majority of breast cancers are driven hormonally. Do we know what's potentially disrupting this natural hormonal balance, is causing these hormonal shifts that can eventually lead to metastatic disease?
I think that it's always, and I wouldn't necessarily say that something has changed in the biology of it. I think they've always been there. I think that we just now know what to call it, basically. And we now have enough research to allow us to have hormonal therapy to treat those things. So I'm not sure that anything has necessarily changed within like what it was before to now in terms of the hormone receptors. I think now we just know enough information to be able to label it as that and then develop drugs to help target it.
I'm just going to keep asking these questions until we chime in. So if anybody wants to just step right in, please do so. But I have a couple of questions in some of our other conversations with one of our colleagues who works for the Hopi Nation. There is, and I think our center also reflects this as well in a lot of our work, is we're, the concern over the role that the environment's playing in cancer rates. Have you seen any data or studies, or you have any inclination, or maybe it's your intuition telling you that the environment it plays some type of role in breast cancer rates?
I'm not sure if I have any specific study or kind of tie-in with breast cancer specifically, but I know in a lot of other cancers, there definitely is an environmental component, especially in areas, that have like uranium mining and things where there's just this contamination within the environment itself. There's no way that that's not being cross-contaminated to the people who reside in those areas. And I think those obviously lend itself to increased breast cancer, or not breast cancer, just cancer risk in general.
Yeah, that would be, one of our colleagues is working out west and is going to be doing some work for us as well out here in Western New York to look at some of those potential relationships between contaminated environment and risks of various cancers.
Yeah, I mean, currently I'm on the soft tissue sarcoma melanoma service here at Roswell. And I mean, even people who have a lot of exposure to like herbicides and pesticides or radiation from maybe like a radiation leak, they are also at increased risk for like a soft tissue sarcoma kind of cancer. So there's definitely other associations. There may be one for breast cancer that I don't know of, or we just haven't identified it yet.
We have our first question. Is there any organization on reservations to help advocate for better care for Native women?
Yes, actually there are a lot of different tribal initiatives that are happening right now. I know within Navajo Nation, like Tuba City specifically is trying to have its own oncology kind of center because they have noticed that a lot of people have to go elsewhere to get care. So there's those kind of initiatives. And there's also, aside from just the local ones, there are national organizations that are trying to help with, like American Indian Cancer Foundation, who would be able to know, I think, and link people more to other national organizations or more local organizations that are doing things within each of these tribes specifically. So they're out there, and you just kind of have to look for them.
A good place to start is with the American Indian Cancer Foundation. They're a partner with Dr. Heiser and our group as well. They do a lot of work for communities across the country, and they're really a great one-stop resource. And we hope to follow their lead in our region with our resources. And one of the ways we have utilized our regional data for the betterment of their communities is to identify these problems and create solutions. And Dr. Herring has created many of them, but I think one of the important ways we could advocate for Native men and women is through our navigators. I think the navigators provide a critical link, and our educators as well. Educators and navigators being advocates for our communities who are oftentimes long distance away from our cancer centers, our cancer treatment centers, for example, or screening facilities. So I think they play an important piece. And also identifying, I think, identifying the communities, what the needs of the community are. And I think a lot of our work that we're doing now, as well as yourself, Dr. Heiser, are helping to identify the specific needs of those communities so we know how to best help. Is there any other questions on our panel today? Well, then I think what we'll do then is, since this is, we have one come right in. The next question is there a need for more indigenous providers in Indian country?
Absolutely.
Perfect question for yourself.
100%. I think that that is absolutely true. I think that American Indian populations and Alaska Native tribes need to have their own providers who know, the needs of their own communities, kind of what Will was saying a little bit earlier. There's just a different mindset, a different way of beliefs and traditional beliefs that I think a lot of more westernized providers just don't understand, don't have the access to. So I think it is absolutely important for American Indians to have more representation within the healthcare fields overall. And I know that there are some initiatives for those, like Dr. Brote and Amanda Brugel. Dr. Brugel over in Portland are really trying to emphasize that as well, trying to get more representation within healthcare for Indigenous tribes specifically, because I think that's a really great need and nobody knows what we need better than ourselves.
How has your, your indigenous beliefs or your indigenous values shaped your career as a surgeon, as a physician, as one who cares, is on the front line caring for our sick community?
I think that it's been absolutely instrumental in getting me to where I am now and kind of shaping my idea of how patient care should be. Because I think overall, we approach things tend to be more holistically, and we think about the spiritual, the mental, the physical aspects to each individual, and how the community kind of plays a role in all of this as well. So I think that helps me as a provider to kind of think about those things and realize that it's not just this disease itself that's impacting this patient. There's other parts of their whole being that are kind of playing into all of this. And so I think that helps me plan things and kind of approach the multidisciplinary care that we provide patients, usually in oncology centers, to kind of keep that all in mind and kind of guide and focus it.
Well, we have two more questions coming in. I want to make sure we get to them both. The next question is, if we need more representation of Indigenous people, how did you get through the medical system?
That's a great question. How did I often wonder that myself. Because I think it's true. I mean, you just don't see people like me or, other American Indians who are physicians being in this position. And I think I'm a product of great mentorship. And I think that's one of the really key things. And also just daring greatly, in a sense, because not a lot of people will make it off the reservation. Not a lot of people will get secondary education or graduate level education. And I think sometimes we are our own worst enemies. And I know for myself, that's been true also, because all along the way, I kind of was like, I'm not supposed to be here, constant imposter syndrome. And, even to this day, sometimes that happens. But at some point during my career and training, I realized that the only person that's hurting is myself. So you just can't be your own barrier. And really, you just have to keep asking questions. There are a lot of organizations that help with mentoring. So specifically, like the Association for Native American Medical Students that I was a part of, and the American Indian Association for American Indian Physicians, all are people who have blazed this trail and are more than happy to give other people more mentorship and kind of guide them of like what steps are to come. Because I think that's the hardest part of being someone who doesn't have any family within this, is that you don't know the steps, you don't know how to get to certain places. And so those national organizations are a really good branching point. And if you contact them, guaranteed they will give you somebody who will get in touch with you and kind of help foster you through this.
That's a very important piece of information to any of our viewers who are aspiring Indigenous physicians or healthcare workers. Our next question starts with a comment. Thank you for the great talk, Dr. Heiser. Are there any indications why hormone negative breast cancer is more common than hormone positive? Is genetics playing a bigger role than environment, or is it both?
I think it could be both, and I don't think that we have enough information to say that, especially within American Indian Alaska Natives. I think there's a lot more research within this within non-Hispanic Black communities, because that's usually the communities that present with it more. So they're looking more at genetics and things like that. But within American Indians, Alaska Natives, I don't think that there's good information to look at in regards to that.
Yeah, that's another, another issue we're tackling through our research is the lack of data, the lack of research is we really don't know. We have really no idea if it is genetics, environment, it's both. Likely it's both. I think that's a assumption, but we don't have any real solid research to back it up. And that's why these conversations regarding research are so important at a national level for all of our tribal communities.
Yeah.
I think that, from our experience, I'm sure your own, some communities have more robust data regarding, as it relates to research, and some have very little, if any at all. So it's very difficult to ascertain a general idea from such sparse information in our communities. But these conversations, lend to bigger discussions and hopefully lead to potentially more research and solutions.
Yeah.
And I think this is a great way to honor Breast Cancer Awareness Month, and that was the original intention of this discussion. I think it did much more than that, but I do believe that this is one of the best ways we can honor our Indigenous community members who have been affected by breast cancer, whether you've been directly affected or your family has, and having these open discussions, humanizing the work, research and the work you do as a surgeon, and humanizing that is very, very important. So we're very grateful. We're very grateful, as we always are, for our speakers for joining us on Breast Cancer Awareness Month and providing such a robust look into breast cancer in our Indigenous communities. So with that, do you have any final remarks that you want to give to our viewers today?
Go get screened. No, I think just thank you for this opportunity. It's been, kind of years in the making as far as kind of looking at this stuff specifically and giving me the platform to do so. I'm very grateful.
Likewise, we're very grateful to have you. Thank you, everybody, for joining us, and look for our next webinar speaker. Our next webinar series is the third fourth Wednesday of every month. Sorry, we have a lot going on here at our center, but it's the fourth Wednesday of every month. So look forward to the next speaker series. And one of the last comments that I think we all can share here is, and I think we all share the same perspective, this has been a wonderful perspective. Thank you for sharing this information. I think we all echo those same sentiments. So thank you, Dr. Heiser.
Thank you. All
right, take care.
Okay, bye.